Good evening, everybody. Can everyone hear me okay? Yes. Great. I'm Michael Rugg. I'm the director of UT Dallas's Center for Vital Longevity. It's my great pleasure to welcome you to the 11th, believe it or not, the 11th Gene and Bill Busiotis Distinguished Lecture. The lecture was funded by a generous endowment from the estate of the late Gene and Bill Busiotis. It's a great pleasure to welcome members of the Busiotis family who are with us here tonight. And it's especially fitting that this lecture is taking place in this facility, wonderful building, because Bill Busiotis was its architect. So it is very lovely to be able to pay homage every year to Bill by using the fantastic space that he designed. I'm going to hand over right now briefly to Ms. Ember Price, who is a representative of the Communities Foundation of Texas, is going to say a few words on behalf of the foundation. Ms. Price, please.
Good evening. My name is Amber Price, and I am Donor Services Coordinator here at Communities Foundation of Texas. I am one of the many people responsible for stewarding and engaging the individuals, families, and organizations who partner with CFT for their charitable giving, including the Busiotis family who had a fund here. We are absolutely delighted to have you in our building today for this lecture series. At CFT, our vision is a thriving community for all. We work to make our vision a reality by growing community giving, expanding community impact, and advancing community equity. Our aim is to move people from surviving to thriving through the 4 pillars of our work: health, wealth, living, and learning. If you are unfamiliar with our work, you may be familiar with North Texas Giving Day, which is one of our largest community investment initiatives. Whether you realized it or not, if you gave to a nonprofit organization on North Texas Giving Day in September, you partnered with us to raise more than $68 million for nonprofits this year. Yeah, big number. That's our biggest one yet. For over 70 years, we have served as a trusted advisor in our community, and we're here to offer philanthropic guidance and services to support the causes that matter the most to individuals like you. We would love to walk alongside you in your generosity. If you're interested in any of the work that we do and you would like to be involved, please visit our website at www.cftexas.org. Thank you for your time and enjoy your evening.
Thank you so much, Amber. Thank you. I'm now going to invite Dr. Joe Pancrazio, who is the Vice President for Research at UT Dallas, who is going to say some words on behalf of the university, and I hope extol the Center for Vital Longevity along the way. Joe, please.
Thank you, Mick. Thank you, everyone, and thank you, Mick, for the opportunity to come and welcome our speaker and welcome you all this evening. It's one of my favorite events. It's enlightening, it's engaging, and oftentimes relevant to what we all experience and growing with in terms of our own cognitive function. So I think cognitive function is something we can all appreciate after recent events. With that, on behalf of the University of Texas at Dallas, I'm happy to welcome our speaker, Dr. Rachel Buckley, Assistant Professor of Neurology at Harvard Medical School. I'd like to think of UT Dallas as the Harvard Richardson, Texas. So come visit us every time. I also want to acknowledge my boss, Richard Benson, who's had, is closing out a wonderful career at UT Dallas, been inspirational in many of the aspects that we really care greatly about, and especially as it touches my area in terms of research. Now, Professor Rugg is going to give probably a more comprehensive introduction for Dr. Buckley, but I want to share a little bit of academic insider baseball for you. Dr. Buckley is in an early stage of her academic career, but her H-index, Google H-index, which is a measure of researchers' productivity and impact, is 44, and what that means is it's stratospheric, and shows no signs of dissipating. If you look at it, just rocketing up. It would be the envy of many full professors, and with it, we're delighted to have you here. I'm looking forward to the talk. So I serve as the Vice President for Research and Innovation, and let me share with you in kind of a shameless way some of the success that we've had. November is the time of the year, not just for elections, but also for us to be able to take stock of the numbers. In other words, how are we doing in terms of research? And I'm pleased to report this last year has been incredibly productive for UTD research. We've had record levels of research expenditures. We've met and surpassed our goal for our strategic plan goal, but we've done so a year early. And this is a testimony to the faculty and their insights, their competitiveness, our deans, our provosts, who are really kind of setting the stage of how do you have impact in the world and through the research and knowledge creation. Now, what's good is the cupboard's not unlikely to go empty anytime soon. This last year, we had even a 10% increase in the proposals being submitted. Oh, that's pretty good. We had a 15% increase in number of awards. Okay, we had a 25% increase in the total award amounts that are coming. So all the indicators for UTD and UTD research are going and increasing on an upward trajectory. Now, central to our research, and this is the paid-for political announcement from Mick, is our own Center for Vital Longevity, and I'm quite sincere. The center is an expanded and compelling mission now, better understand and promote cognitive health throughout the entire lifespan. And two notable research awards that kind of encapsulate or capture that. And that, Dr. Noah Offen, who's here, with their NIH project that's oriented around development of memory networks in children. Okay, and of course Mick Rugg, who has an NIH project, neuroselectivity retrieval, related reinstatement, and age-related memory decline. So covering really lifespan. That's excellent leadership by example. We need all our center directors like that. And at the very beginning of this year, Dr. Karen Rodriguez and Kristen Kennedy earned support for their NIH R1, dopaminergic neuroplastic influences, longitudinal change in cognitive and brain aging. It's going to make use of a 7 Tesla magnet to get all this incredibly detailed information about brain. So clearly the Center for Vital Longevity and the associated scientists are leading the way for our university research impact, and we tremendously value their contributions to the leadership. So I'm going to return the podium back to Professor Rugg, and we'll introduce our guest speaker.
Thank you very much, Joe. Thank you. That's great. All right, so we're on to the main event. It is my great pleasure to introduce tonight's speaker, Dr. Rachel Buckley. She received her PhD from the University of Melbourne. That's Melbourne, Australia, not Melbourne, Florida, as you will soon discover. And she's currently an associate professor. You need to update your website. We should congratulate you on your promotion. Yeah. An associate professor of neurology at Harvard Medical School. She also serves as chair of the Alzheimer's Association Sex and Gender Differences in Alzheimer's Disease Professional Interest Area. Dr. Buckley is an expert on sex differences in aging and Alzheimer's disease, and she's the author of more than 150 research papers in these and related fields. Please join me in welcoming her, don't need to welcome me, to her talk on why women's brain health deserves a closer look in Alzheimer's disease. Thank you.
Wow, I sound very impressive. I wish my parents were here. So thank you all so much for coming. Thank you so much to Mick for the huge honor of being invited to speak today. I hope today I can impart sort of a few words about women's health, women's brain health in particular. But I want to come at it from a broad lens and then dive in a little bit and then come back out. And I hope that what we will sort of go through today as a journey in this talk will be some sort of feelings of excitement, as well as feelings of a burning desire to continue the research. Because where we're at in women's brain health research is at an exciting time, where lots of things are happening because not much has been done. So I think this will be a fantastic point to sort of light a fire under people and to continue that message. So let's take a 60,000-foot view first, and then let's just think about sex differences in disease burden across many diseases in the United States. So let's think about this is a fantastic article that came out in the Nature magazine a little while ago, earlier this year, so some of you may be familiar with it. But what they wanted to do was to take disease burden and sort of pictorially describe the amount of disease burden and how it might affect each sex. So each of these circles here represents a different form of disease, and the size of the circle is the amount of disease burden, so mortality and disability that it can cause. The grey circles that you can see here are those that indicate no apparent sex differences. There are some, caveats to this, but on the whole, these diseases up on the screen that you see here in grey do not tend to show a very sort of consistent sex difference. What I'm now showing you in the sort of orangey red colour is the diseases, and you don't need to have them sort of labelled. This is just a sort of a pictorial example of the amount of diseases that are much more female biased in the level of disease burden from both mortality and disability. And this final pictorial depiction is the male disease burden. These are diseases that sort of just, or not just solely, but mainly affect men. Now, if we take all of these circles and rank order them according to the amount of disease burden, so the largest circles on one end and the smallest circles on the other, the first thing that you can visualize and these are just the circles that are showing some kind of sex bias, you can immediately ascertain without any statistics that the female slanted disease burden circles seem to be more on that upper end. But if you then resort everything based on the amount of funding at a national level that is applied to these diseases, you can see that a lot of these circles, particularly the ones that are female biased, are down the other end. And this is a problem. It has been a problem for many decades, and there is a lot to be said for huge institutions like the NIH who are doing a huge amount to try to rectify this issue. But one cannot deny that there has been a age-old saying that if it works in men, it works. And let's just take an example of an anti-amyloid therapeutic. This is in my backyard. This is my area of passion, which is Alzheimer's disease research. One of the biggest Alzheimer's disease medications that was recently approved by the FDA was the lecanemab drug, now called Leqembi. In that particular paper, this was a huge, huge amount of news that came out in the media. You would have seen it. When it was published in the New England Journal of Medicine, they reported a 32% cognitive benefit in the people who were treated with lecanemab throughout the trial. That is an amazing accomplishment. But what they didn't report in the main area of the manuscript, what they reported in page 33 of the supplementary section, is that men had a 42% clinical benefit, women had only 12%. We don't know why that might be, and it's not the fault of the authors, it's just simply because it wasn't really powered for in the trial. And what I mean by that is these trials are very expensive, and in order to be able to really do justice to understand how subgroups of individuals in clinical trials are actually showing benefit or not, you need to be able to have enough people in each of those subgroups to be able to run those analyses. Right now we don't have that, but we need to do it. So let's just take a step back and talk about what Alzheimer's disease is. Alzheimer's disease is not the dementia. The disease is actually defined by proteins, disease in the actual brain. There's two hallmark proteins that we see in Alzheimer's disease, amyloid and tau. You may have heard of these terms before. These are two very, very well-known proteins that we can actually measure now in the brains of people who are living, but most commonly when we are definitively diagnosing Alzheimer's disease, it's in post-mortem cases. The dementia, on the other hand, is the clinical syndrome, the things that we can observe, memory change, other thinking skills changing, the inability to be able to perform normal daily activities, paying bills, being able to remember where your child's white sock is that they really want to be able to wear that day at school. All these sorts of things are the sort of the syndrome, the clinical side. Now, the dementia can be driven by lots of different diseases. Alzheimer's disease is just one, but it is the most common. And there are many ways that we can actually measure both the disease proteins as well as the cognition. For the disease proteins, we tend to look at neuroimaging. This is our specialty in our lab at MGH in Boston. We tend to do a lot of amyloid positron emission tomography and tau PET. How we do that is we get a radio tracer, we inject it into the bloodstream, it passes through the blood-brain barrier and binds to the protein of interest. And what you can see on these scans is a stronger color, so the hotter the color, the redder the color, the more of that particular protein there is. And you can also tell where it is in the brain, so it gives you both an understanding of anatomy as well as severity. In addition, though, and you would have seen this in the news as well, we also now have blood tests, which is really exciting. And so we can measure circulating amounts of these proteins in the blood, as well as in the cerebrospinal fluid. We've had that ability to do that for a long time, but people don't really love getting spinal taps, funnily enough. And finally, we also do a lot of cognitive testing. So now we've covered some of the basics. Let's get back to what I'm really passionate about, which is women's health. Women are at greater risk of dementia, particularly Alzheimer's disease dementia. Of all patients currently living with Alzheimer's disease dementia in the United States, 2/3 of those are women. But it's not just living with dementia, they are more likely to die with dementia as well, particularly after the age of 80. The interesting thing, though, is it's not just really being a woman, because there's lots of women that don't get dementia. But what we have seen is that one of the genetic variants, the apolipoprotein epsilon 4 allele, which is called ApoE4 for short, it is the strongest genetic risk factor for the garden variety sporadic Alzheimer's disease dementia. We found that women who carry ApoE4 are at greater risk than men who carry ApoE4. And what you can see on this slide, on this graph, is this dashed line. This dashed line with the triangles indicates the women who are E4 carriers, and the solid line is the men. What you can see most strikingly is they're not just higher risk the entire way through life, but between the ages of 65 and 75, there is much greater risk of progressing to dementia in this group. This age range is really interesting to me because one thing that statisticians have told us over a decade or more now about Alzheimer's disease is the point at which amyloid first appears on the scene and the point at which someone is finally diagnosed with dementia is approximately 20 years. So if you cast your mind back, 65 to 75 minus 20 is smack bang around the time of a massive hormonal cessation event in a woman's life, menopause. So menopause is a really huge moment endocrinologically. There is a change in the amount of estrogen and estrogen levels, but there's also other things going on in that time where hormone therapy use might come online for some women, and surgical intervention, maybe a removal of a hysterectomy or oophorectomy might be involved. And if you think about all of these things happening in that time of life, and you think about the duration of when these sort of greatest risks are coming online for women for dementia, this is why we're really interested in menopause. And I'm going to come back to it in a second, because what I want to show you first is not just about the dementia, but I want to show you also that women do have greater risk of the disease itself. The first findings came out in 2018, would you believe? That's quite recent, actually. This was actually 2 papers came out in the same year from 2 totally different autopsy data sets. Each of these data sets was nearly 1,000 in number, and they were interested in looking at sex differences in the amount of neuropathology, so the amount of proteins in these autopsied brains. And what they looked at was the amyloid plaques and the tau tangles. Now, there was nothing to write home about for amyloid. They didn't see anything, no differences between the sexes. What I'm showing you here on the graph is neurofibrillary tau tangles. And what they found, I want you to sort of hone in a little bit on the murky brown yellow and the salmony orange colors. These are areas that are signifying hippocampal formation regions. Now, the hippocampus is really important for memory and many different thinking faculties. And these areas tend to show a lot of tau, even earlier on in life. What they found was particularly between the ages of 50 and 70, women showed much higher levels of tau tangles in these brains than men. And these age ranges, again, very similar to what we're thinking about as crucial times post-menopause. But we thought, okay, this is great, but it's all end-of-life stuff. Can we see things in the brains of women versus men while they're alive? And indeed, we can. What I'm showing you here is actually a slightly different form of the same sort of tau PET data. So what I'm showing you here is actually grouped data. It's on average, what is the difference between women and men in the amount of tau PET signal in different areas of the brain. So anything that is blue all the way to red is showing you higher levels of tau in women relative to men. And the first thing that really struck us, because the autopsy data said, okay, there are sex differences, it's primarily in the hippocampus. If you think of a baseball glove, apologies for this because I'm Australian, we don't do baseball, but this is sort of a baseball. This is sort of the hippocampus, sort of tucked in behind the ear, right? They said just there, that's the only place you're going to see it. When we started to image people in vivo while they're alive, we saw sex differences everywhere. Fascinating. And these higher levels of tau in women were really driving faster rates of change in memory over time. Where I want you to focus is that final panel on your right-hand side, which that final panel is the highest levels of tau. We sort of equated men and women. We said, okay, all right, well, what if both men and women have similarly high levels of tau? What happens to women? And in that particular situation, what you see here is a waterfall effect. That's what I like to call it, where all of these sort of spaghetti plot lines are just falling off. And all those red lines are lines that are women. And all the men seem to be staying pretty stable. So we were doing a lot of work just describing. All we were doing is group comparison. How do men and women do? We weren't trying to understand why. The reason why was because no one had even observed these differences. But once you start observing it enough and replicating enough, you start feeling, okay, we should probably try to figure out what's going on here. The first thing we were interested in is menopause. There's a good reason for it. I've talked about it a little bit now in the talk. And I wanted to just sort of highlight how peculiar menopause is in the community nowadays, because it's something that every woman goes through, and yet we don't talk about it. And I wanted to highlight that through a video clip that really struck me from a couple of very famous women that you may know.
You know, it happened to me around 52, 53, and I thought I was dying. I really did, because I did not have, did you have hot flashes?
I started hormone therapy.
Okay, so yeah. I didn't know nothing about that.
See, and that's what we didn't know.
That's what I mean. People don't talk about it.
And here's the thing. People don't research us as women.
Right.
Why don't we know all about this?
And why don't we? It's absolutely crazy when you think about it. But what I would like to argue is what is currently unknown is absolutely knowable. A few years ago, this is one of the first articles that I saw come out in 2018. It's a very small sample, 16 women in each group. They had to be asymptomatic perimenopausal or postmenopausal. And so they were just simply interested in, are these women different from their age-matched men? And what they found was, yeah, there were differences. There was more amyloid, there was smaller brain volume, and smaller white matter. There was some changes. We then took that a little bit further and we thought, okay, so amyloid, that's interesting, but what about tau? Because that's what we seem to be seeing so much in the autopsy literature and in our PET imaging. And indeed, we found that women who were postmenopausal had higher levels of tau. These are much younger women than the graphs that I showed you before. These women were showing much higher levels of tau than age-matched men and premenopausal women. But we took it one step further because it's great to just look at groups, but what about the menopause is actually playing a role potentially? And this is work from my incredible postdoc, who's now actually junior faculty, Dr. Gillian Coughlin at MGH. She was really interested in what elements of menopause might be driving this. And she looked a little bit at the symptoms, and there wasn't really a huge amount there, but one thing that came out over and over and over again was age at menopause. Earlier age at menopause, particularly those women who had onset very, very early, we're talking premature, at 40 or younger, were showing much higher levels of tau than any other group. Now, this age at menopause factor has been known for a while now to be a risk factor. What we have known in the literature for many years, at least at a dementia level, maybe not in PET imaging, but at a dementia level, we see that there is higher levels of risk for progressing to dementia if you have an earlier age at menopause. And when we talk about earlier age at menopause, we're typically thinking about either earlier than the average age, which is about 51, or much earlier, which is below 45. There are also a lot of studies looking at surgical history, surgical menopause. And the rationale behind that is not because surgery in and of itself is risky, which it is not, but it is easier to determine exactly when the hormones have seeded, essentially. Because asking a woman when exactly did menopause occur to you 20 years ago, women are actually pretty good at that, but menopause can actually go for many, many years, and it's hard to determine exactly when the hormones stopped. So here, this particular graph is showing you in the purple line, the very lowest line showing the steepest decline in memory. That is the line of women showing or reporting an age at surgical menopause of below 38. And you can see here, it just gradates up. So the earlier your age at menopause, the faster your memory decline. One of the reasons behind this is because there's an argument that the earlier the time that that estrogen leaves your body, the more you're sort of exposing yourself to risks. The reason is because estrogen is considered a bit of a superpower. It is a potent and well-known neurogenesis factor. It helps to grow new cells, grow new synapses, and keep the brain sort of ticking over. It is also a fuel in the brain. And finally, it is very well supporting of the vasculature in the brain. It helps to create new vessels as well as maintain them. So when estrogen leaves the body, it also impacts the brain. So then, if that's the case, what's the story with hormone therapy? Surely you should be able to reintroduce hormones back in the body and you should be good, right? Unfortunately, that's not the simple story. So as I'm showing you here is an argument for the estrogen window of opportunity. The argument for this theory is that you can replace estrogen and it won't necessarily do a bad thing. It won't necessarily always be super protective either. But the one thing you cannot do is replace hormone therapy after a long gap. So the first few bars here that you see on the very left-hand side are those people who go through a spontaneous menopause. They are able to conserve their ovaries and have, a natural a point at which their menopause occurs around 50. The middle bars are showing those people who go through menopause but then initiate hormone therapy right around the time of menopause. And those two groups, everything in those two groups are showing actually a bit of protection or nothing. So there's either no, benefit or there's a bit of protection. The group that show quite a lot of risk, and this is for dementia in particular, is the group at the very end. These are women who have initiated hormone therapy far later in their life. How do we know this? Because the Women's Health Initiative, which is one of the biggest clinical trials that was ever conducted in the whole world for anything, it was on, well, except for statins, I suppose, that was a big one too. But this one was on hormone therapy use. They had to halt the trial early in the early 2000s because they found skyrocketing risk for a whole range of different outcomes. Osteoporosis, cancer, you name it, they came across it. They also found increased risk of dementia in these women. But guess what these women were? They were older. They were over 65 when they initiated hormone therapy. So that would have been about 15 years for many women between the time they went through menopause to the time when they initiated. Those are the women who showed really high risk. So we thought we'd go back to our Tau PET images because we just love those images. And we thought we would try out that story too and see if it does hold up. The first thing that Gillian did on the very left-hand side is she split the groups into whether women reported using hormone therapy, whether they didn't report using it, or whether they were age-matched men. And the women who reported using hormone therapy are in the yellow. And those are the women who showed much higher levels of Tau. And that was so confusing to us because we thought, okay, you're reintroducing hormones, so surely that should be actually quite protective. And it wasn't. But the story doesn't end there because on the right-hand side, you can see that same group, the yellow group. Then she split those users into 3 groups. The groups were either initiating hormone therapy around the time of menopause or around thereabouts or much later. And the much later group are in yellow. And you can see that group is the only group where there is variability in the amount of Tau. So why do we give hormone therapy? There's a very good reason, and after the Women's Health Initiative findings came out, prescriptions for hormone therapy took a nosedive and they dropped by 80%, and it hasn't ever recovered in the United States. Each country has different ways of handling this, but we know right now that of all the symptoms that you can get, a lot of them are quite debilitating, and I'm not sure who in the audience has gone through these symptoms, but many of us would. And these hot flushes in particular are quite debilitating, can be very disruptive to daily life. And the one very well-known and most effective treatment for hot flushes in particular is hormone therapy. Current guidelines are that hormone therapy is okay to take. And this is from the National Menopause Society in America. And it can be taken right around the time of menopause for a certain period of time, i.e. use responsibly. But a delaying action, if you delay it at any moment, they do not recommend taking hormone therapy. Now, does this reduce or completely avoid your risk of getting dementia? Unfortunately not. It would be great if estrogen alone was the answer to being able to reduce women's risk for dementia. But unfortunately, the story is complicated, and estrogen is not really the silver bullet. What about the X chromosome? The X chromosome story is fascinating. Women live longer across the globe. Doesn't matter where you drop a pin, women are going to live longer there. And in fact, women also live longer with dementia, which goes to show this story is not really about susceptibility or vulnerability, because I hate using those words. Women are actually incredibly resilient as well. And the X chromosome tells that story beautifully. Why do we care about the X chromosome? And how does that factor into longevity? Well, on this right-hand side of this graph, you can see a lot of dots here. You'll see blue dots and red dots. The blue dots indicate let me start off first by explaining what a heterogametic sex is. So heterogametic sex is when you have X and Y, so 2 things that are sort of complementary to one another. And a homogametic is when you have 2 of the same thing, so XX would be the example. You can have female homogametics, which is XX females, which is the human species, and you can have male homogametics as well, and that is in other species. You can flip that on its head And you can see here on the right-hand side, they're talking about heterogametic sexes dying early. And on that right-hand side panel here, most species that are heterogametic, so in this case, in the human case, it would be XY, that anything that is heterogametic tends to die earlier, even if they have ovaries. So there's something about this repeated sex chromosome that seems to put people in a bit of a bind. And it sort of gives women, in the human case, a bit of a superpower. The rationale behind that is because you get an X from your mum and an X from your dad, and if there is a mutation on that one X from your mum, you're able to account for it, compensate for it, and be able to continue on and therefore have a lot longer, have more longevity. The other thing about the X, which is fascinating in women, is that in order to avoid overdosing, because that's not fair on men, they randomly, in every single cell of your body, one of the X's will just turn off. And it's a biological function in every single woman. The fascinating thing about that is that not all of those genes will turn off. So every single woman I'm looking at right now, all of you have a different cocktail of genes that have escaped inactivation. Each one of us is different. But some of these genes consistently across all of us tend to escape, and those tend to be immune-related, which is why women are a little bit more likely to get autoimmune disorders, but they also tended to fare a lot better in COVID. They are less likely to get cancers. There's a few reasons why the second X and X inactivation is so fascinating. In addition to that, we have done some work, and so has Dr. Dina Jubal at UCSF, who's like a hero of mine, have looked at some of these genes that tend to escape inactivation on the X chromosome to see what do they do in relation to risk for Alzheimer's disease. This is just one example here. This is a circus plot, and what we're showing is the genes, all the genes that are sticking out like a spoke on a wheel, I guess. All of those genes are genes that are significantly associated with change in memory. Where you see the blue, it's kind of hard to see, apologies, but where you see blue, those genes are protective. They are associating with better cognitive performance than men on that X-axis, on the X chromosome. And for that orange, we're seeing worse performance. So the X is amazing because it doesn't just impart risk, but there are lots of incredible potential genes that can be protective. So we have a lot of questions still remaining. We know that both genes and hormones play an important role in trying to understand Alzheimer's disease risk, and they not only have a direct impact on the biology, but they are having an indirect flow. And I'm not going to show all this data, but trust me on this. Menopause impacts metabolic syndrome, disrupted sleep, poor mood, cardiovascular risk, hormone therapy use is coming online. And the X chromosome has these very interesting pathways through immune systems and neuroinflammation to exacerbate or moderate risk for Alzheimer's disease. But there are so many questions that remain. What is the ApoE4 doing? Why is that so important in women? Why is it increasing risk? Is there some kind of survivor bias here when we're looking at these data? Is it that men simply die out earlier, so we're not really measuring the right men? Or the men look incredibly healthy because they're the ones that survived? And how do we know across women what's going on, in different races and ethnicities? And finally, is the story about susceptibility? Or is it actually a really powerful story about resilience? So I want to take this back and just remind everyone again where we started. There are so many questions that we don't have answers to yet, but we should all be beating the drum to try to get to the bottom of it. There are some new initiatives out there to get excited about. One of them is I'm on a scientific advisory board for the Ann S. Bowers Women's Brain Health Initiative coming out of the Universities of California, where they want to start something called the Longitudinal Menopause Project. It's kind of a time capsule study where they want to start doing deep phenotyping. Look at all of that data on the screen there. They want to gather that in about 10,000 women from across the US, and they want to follow women every 5 years for as long as they possibly can and see what happens to them. And I want to end with a video that they created and that I find really exciting. And it sort of got me excited about the future. So here it is.
Let's start with some good news. Neuroscience is having a moment. We are learning more about our brains than ever before. Over 50,000 neuroimaging articles have been published since 1995, shedding light on the most complex organ in the human body. Of those 50,000 articles, about half of the test subjects are women, and yet only half of 1% center on matters specific to women's bodies. Wait, that can't be right. Half of 1%? Guess that brings us to the bad news. Half of 1% is so damn small. It's this small and this little. If you made a pie chart, let's say boysenberry, half of 1% is that. There. That's the entirety of what we know about brain health and the fork crumbs.
Here's a list of things we know more about than the female brain.
The ocean floor, male pattern baldness,
Dinos.
erectile dysfunction, how to make erectile dysfunction medicine chewable and yummy, artificial sheep uteruses, LeBron James's off-season diet,
Outer space.
outer space, meaning if men really were from Mars and women were actually from Venus, we might know more about menopause by now. Even in cases like Alzheimer's, which mostly affects women, preclinical research relies on male models. The assumption is if it works for men, it works. And that doesn't work. The most recently approved Alzheimer's drug shows positive effects primarily in men. One size fits all is actually one size fits half. And in this case, it's the wrong half. When 99.5% of all neuroscience research excludes matters of women's health, mysterious things stay that way.
Why do women get Alzheimer's more often than men?
Is my birth control making me depressed?
Are concussions different in girls?
Why can't I remember anyone's name anymore?
Why am I so sleepy,
Sad.
hungry?
Am I undercaffeinated or is this
A menopause thing?
Jury is still out because nobody bothered to put any women on the jury. The male body has been the standard since always. Lab rats, male. Clinical test subjects, men. The tenured neuroscience faculty, 80% tweed elbow patches. But what if, maybe, what if we set fire to the status quo? Demand better, broader data.
Study women.
Thousands of them. We start a revolution in neuroscience. Or join those who already have.
Very good. Very good. And with that, I would like to say thank you so much for listening to this talk. I'd like to acknowledge all of my colleagues and friends, and also my two beautiful little girls who keep me doing the science that I love. Thanks very much.
Thank you so much, Rachel. Fantastic talk. We have time for questions. If you could put your hand up, one of our microphone bearers will bring a mic to you. Yes, right at the front here, first question. Here comes the mic.
I'd like to know if there's been a study or if you have any knowledge of COVID affecting your brain and if it can be conducive to dementia or Alzheimer's.
It's a very good question. There have been some studies at an epidemiological level potentially linking some ideas of maybe there being COVID with dementia, but it's been correlational at best. I don't think we have enough data or enough longevity, honestly. What we really need is long enough time points to be able to point to this. So unfortunately, that's not my area of research. I'd have to go digging. I'm more than happy to go back to you on it. It's a great question. But what I do know and what I found really fascinating about COVID is that, you know, that man flu idea, it's a real thing. Men really were impacted a lot more by COVID symptoms than women. And there were some really fascinating studies that were coming out to try to tackle why that might be. Yeah. Yeah, of course.
Yes, Scott.
I'm a guy, but I was fascinated because my wife is sitting next to me. And I was someone that was studying to be a pediatrician, umpteen years ago.
Yeah.
My question is to you is this: as we walk out of here, whether I am a man or whether I'm, learning about more for my daughter or my wife,
Yeah.
what is the takeaway as we walk out of here? You travel obviously all over the country. You're up in Boston. You're up at Harvard. But what is the takeaway of everything what you just shared with us? What is it that you want us to take home, share with our family and friends, and really, as we move forward, beginning tomorrow morning, some of the things that we need to do with the females in our life, young or old, but as they move forward, what is it that we should be concerned about and that we should watch for and be a part of from this point on?
So there's two elements that I think about at a broader societal level. One is to empower and educate, and it doesn't matter who that is, but empower and educate and advocate for the women, just at a societal level. And the other thing that I am really personally aware of, because I'm actually an E4 carrier and I'm a woman, and I have a lot of women in my life that have been so inspirational to me. And I think the one thing that's always come through is to be careful not to pathologize. Because to understand women's brain health is not to consider women are a new condition. They're not a condition. It's just that we have neglected to include information or to publish information. So one thing that we don't tend to do necessarily, or we're doing a lot better now, but we didn't traditionally, is just to simply sex disaggregate our findings. And what I mean by that is just to report how did the women go, how did the men go, or even to include female rats or women in clinical trials. And in doing so now, to shed light and say we are going to focus on women is not because we want to pathologize it. So for instance, pregnancy is not a disease, but we need to focus on it because it is something that has been neglected. So there's a very important thing that we need to do is not to induce fear and not to make women feel vulnerable. The point is to empower and educate and advocate. That's what I'd like people to leave here feeling. Thanks for the question.
We have a question over there. Yes, please.
So you speak from the perspective of the Menopause Society, but I can assure you that your average OB-GYN, and even worse, your average oncologist, is completely opposed to the concept of hormone replacement.
Yeah.
And so, as clinicians, work needs to be done to expand what is known about menopause to other practitioners.
Hear, hear. Yep. I don't really have a comment to make there. I do agree. I think that there's a lot of work to be done in this space. There's a lot of women who don't know or have not got education for themselves. I do often urge people to go and speak to their doctor, but then if the doctor themselves is not necessarily well-versed, it does cause a problem. And so there does need to be more education. And I do think that is actually a major initiative that is coming over the next few years for the American Menopause Society and also the international menopause societies as well. It's a great point.
Yep, there's a question here. There's a microphone coming the other way. There you go.
My question concerns inheritance. Can dementia be inherited?
This is a really fantastic question. And yes, there is heritability to Alzheimer's disease. In fact, Alzheimer's disease is estimated to be about 40 to 60% heritable. It's not just E4. There are other elements within the genome that can increase risk. In fact, one study that we recently reported, and this has been in a few different studies, that actually maternal family history can increase risk on either sex. You don't have to be a woman, but if you had a mother who had Alzheimer's disease, that might have an increased risk, and we're still trying to figure out what that might be. There might be a mitochondrial component to that. But yes, there is an inheritance component. Family history does play a role, and it's a collective thing. So there's a lot of different genes that have very, very, very tiny impacts that might play a role. In saying that, there are still a lot of sort of modifiable risk factors involved that can mean that even though you might have, at a general population level or in a study, on average, you have increased risk if you have family history. but you're not doomed with it. It is not the same thing as autosomal dominant Alzheimer's disease, where you have a mutation that will definitively give you the dementia at the age of 40. That is a very rare thing, and there are only certain families in the world that have that. So just because it's inherited does not mean that it is definitive.
I was actually going to ask a similar question about the inheritance and whether or not you would recommend women getting the testing done for the E4 gene.
That is a personal question, a genetic question, because right now, even though we are trialing anti-amyloid therapeutics, we still don't definitively have any drugs that can be sort of put into the water supply or given to people really early on. So it really is sort of a personal decision whether or not you want to know or be disclosed in that way. I chose to do it because I wanted to know and be able to prepare myself. Maybe I might want to change some of my lifestyle factors, and I have done that, my own personal decision. But it's certainly not something that a doctor would ever, if you walked into a clinic and said, look, I'm worried about my memory, and they'll go, great, let's do an ApoE genetic test on you. That is not something that is done. Mm-hmm. So it really is something that at the moment is really a population level thing. We know that E4 increases risk. But if I looked at one person on the street, or if you looked at me right now, you could not tell me definitively that I was going to get dementia.
Do you follow anyone specifically for lifestyle, diet studies that have been done?
There have been quite a lot of lifestyle and diet studies. One of the biggest clinical trials is Pointer and Finger. So Finger is the first amount of clinical trials that went on, randomized control trials of non-pharmacological intervention, including physical activity, changing diet, things like that. Unfortunately, they have not had the kind of moving of the needle that we would really like. In saying that, doesn't mean we should all throw out the idea of being healthy. What's good for the heart is good for the brain.
We're going to take one last question. I think, Lindsay, you had a question? That was your question. Okay.
So where I did is I actually went to 23andMe, would you believe? Which is now, all of a sudden, out of business. I don't know if everybody saw it.
There's still Ancestry, I think.
I don't know. Does Ancestry do E4? I don't think they do.
I don't know. I got mine done at 23andMe.
I did 23. They did that. 23andMe did it, but the other way that people tend to do it is when they join studies. Often there is an ability. If you join a study, you are able to ask for certain pieces of information. Not everything. Certain pieces of information can be disclosed to you, depending on the amount of ethics approvals that are allowed. Where we are, unfortunately, in Boston, we're not allowed to disclose, but I do know that there are some studies that potentially do that. But 23andMe, the commercial routes are usually the way to go, at least in the United States.
So I'm going to bring formal proceedings to a close at this stage. I would like to thank you again, Rachel, for a fascinating, incredibly informative talk. Please join me in thanking. We look forward to seeing you at future occasions. In particular, look out for advertisements that will come within the next, probably in the new year, for our next public lecture, which will be held on the UTD main campus. And that will be a lecture that we put on in partnership with the Texas Instruments Alumnus Association. It's a very similar format to this, but we hold it in the wilds of Richardson rather than the comfort of Dallas. The other thing to say is that within probably a couple of weeks, the podcast that Rachel graciously recorded today in our center will be on the UTD podcast link. Look out for that. You will be able to find the link. You can find the link to that and all our other podcasts on the CVL website. And enjoy. And there will also be a YouTube video of this presentation, thanks to your signing the release form. So there will be an opportunity to distribute the link to this lecture to your friends and colleagues. And also, as I say, once again, look out for the podcast. Thank you so much for being here. Drive home safely, and we look forward to seeing you again very soon. Thank you so much.